Good afternoon, everyone, and welcome to today's digital event. I think we're going to have a fantastic hour talking about how social prescribing will tackle loneliness, or actually to flip that, how can social prescribing tackle loneliness? Because what you're going to hear over the next 59 minutes is a whole set of insights, but I think also a whole set of questions. So if you're dialing in today, hoping for a nice quiet lunch, where you don't have to use your brain, well, I think that's still fine, but we'd very much like it if it was possible that we could use some of your brain power to help us, I think, in a really interesting task where there are lots of questions, and hopefully we're going to be able to possibly not solve all of them today. We could try, but probably let's see if we can make some progress. My name is Richard Taunt. I'm from Kaleidoscope, helping to facilitate today's session. I'm joined by a Glasgow of stars, Olivia.
Olivia Field, Policy and Engagement Manager for the Red Cross and Co-op Partnership.
Hi, I'm Bev Taylor and I work for NHS England coordinating social prescribing.
And I'm Nick Herrick. I'm with the British Red Cross in Islington on Community Connector.
Thank you all very much indeed for joining, and thanks everyone for tuning in. I know we've got a whole host of people from all over the country joining us today, so thank you very much indeed for giving up your time. A quick recap of the purpose of today. Hopefully this tallies with why you're here. So we're going to be doing a bit of setting the scene, sort of sharing some of our understanding about the current social prescribing landscape with this particular focus on how it can tackle loneliness. So a lot going on about social prescribing. I hope everyone dutifully celebrated Social Prescribing Day last week. I'm sure, Bev, did you have a cake in England?
I was on my holidays, but I did it on Twitter.
Shows that'll count, thank you. So a lot's going on about social prescribing. Today's focus is really about the use of social prescribing to tackle loneliness and how that can be most effective. So we're going to be talking about that overall landscape. We're going to be talking about some of the challenges. We're going to talk about some of the models being used based around link workers. Nick, great that you're able to join us to talk about some of the work going on the ground, so to speak. But particularly what we're really interested in is insights from you. And Livy will talk a bit more about the overall project, which this feeds into in just a moment. 3 ways to join in this afternoon. You can use the Ask Question feature on GoToWebinar and to send us your thoughts and views. If that doesn't work, you're very welcome to email us. hello@kaleidoscope.healthcare is the email address, or very welcome to tweet. Hashtag is tackling loneliness, and our user handle, Twitter handle, is @kscopehealth. And if you're sitting there and suddenly your computer decides it wants to turn to mush and everything crashes around you, do not worry. We are recording today's session, so you'll be able to watch it back later. And indeed, if you are watching it back later, a very warm welcome to you too. We'd still love your thoughts and views via the email address or via Twitter. That go-to question feature is going to be less useful if you're joining after the event, but please do send through your views. Reminder, we're joined today by Olivia, Bev, Nick, and I'm Rich. So I think just before we get going, it'd be lovely just to have a sense of who we have on the call today. So we're going to just have a very quick poll, if that's all right, where the question is, what's the main experience you bring to today's event? You must, and so what's the main experience you bring to today's event? Hopefully, yeah, that is coming in, lovely. So we've got 5 options for you there. If your experience doesn't fit in any of those neat little boxes, then email us to loudly complain and say what experience you are bringing today. We're just going to let that run just for a little bit. 74% of you voted. Thank you very much indeed. Give it a couple more seconds. Lovely, great. Okay, well, let's close that and just have a quick look at the results. So we just need to share those. Lovely, so thank you very much indeed. So you can see that, so it's a close run thing between those providing services and those working in community connection. 39% providing services, 36% community connection. Policy and research coming in, 20%. Some people joining us from commissioning, primary care, some joining from personal experience. Thank you very much indeed. Certainly what I read into that is a great set of views. I think we've got over 75 people joining us today, which is fantastic. Thank you again for your time. Lovely. I think we'll start off properly. Olivia, over to you. How does all this fit into the wider project?
Yeah, so as I mentioned, I work for the British Red Cross and Co-op Partnership that has been seeking to tackle loneliness and social isolation across the UK for a few years. Primarily, together we set up community connector schemes across the country, which are all about providing person-centred, time-limited support with the aim of building up people who are lonely or at risk of loneliness, confidence and independence, so that they're able to connect to local activities, support, community groups, but also to develop the meaningful connections that they would like. Our partnership has also been convening the wider sector via the Loneliness Action Group, which is a large body of voluntary public and private organisations passionate about tackling loneliness, dedicated specifically to driving forward the Joe Cox Commission on Loneliness final recommendations on government and others. And of course, we provide the secretariat to the all-party parliamentary group on loneliness. And a lot of that work has been focused on expanding and improving the social prescribing across actually the whole of the UK, but we're particularly pleased with NHS England's new commitment. We're lucky to have Bev here to do just that.
It's slightly awkward if you at this point you said you were really disappointed with NHS England.
Yeah, it's so difficult.
Yeah, making for a more interesting debate, but okay, sorry.
Well, no, we're here today because NHS England has committed to doing this, and this is all about ensuring that, you know, we A, make it a success, and B, make sure that it effectively tackles loneliness, you know, in and amongst all the other things that social prescribing is there to tackle. So why are we doing all of this? Well, our research, Trapped in a Bubble, shows that over 9 million adults of all ages and all backgrounds feel always or often lonely across the country. We know that people are particularly at risk of loneliness during key life stages and transitions, so from becoming a parent to the onset of a health condition. And we know that whilst everyone does feel lonely from time to time, when people start to feel always or often lonely, they can have like serious negative effects on your health and well-being and much more. So the research shows time and again that feeling lonely often is linked to a whole range of clinical diseases, heart disease, stroke, falls, depression, cognitive decline, Alzheimer's, sleep problems. I mean, the list just really sadly goes on and on. And this actually reflects what the Red Cross is seeing on a day-to-day basis across all of our services. So we see refugees and asylum seekers struggling to form the meaningful connections they would like here in the UK. We see people who've lost a loved one during a terrorist attack, struggling with loneliness, right through to all the people that we're helping home from hospital. And what we see is that these life experiences and crises really can trigger loneliness, but then the experience of loneliness itself can exacerbate these crises. We've done some research of our own services and the people using our health and social care services across the board. And we know that many of these people have quite complex and clinical health and social care needs, but actually loneliness and unwanted isolation are often the two most common underlying issues affecting the people that we're helping. One of the main things that the Red Cross does is help people home from hospital to recover and regain their independence. We're helping hundreds of thousands of people across the country doing that. We've been doing that for many, many years. And very often at that point, people's clinical needs might have been met, but they've got this whole host of non-clinical needs which haven't been met yet. And that compounds their problems. It sees them coming back in and out of hospital, back to their GPs. So that's why we're interested in social prescribing as a whole. What we want to see now is that these moves, which is so exciting, we are recognizing the importance of meeting people's non-clinical needs, but how do we ensure that the expansion and embedding of link workers across the country works well? How do we identify the most pressing unanswered questions and start to unpick them? Because it's not easy to do this. This is a shift in the way that we see what our health and social care provision should be. That's what today is all about. So it's identifying what a strong model of social prescribing in tackling loneliness is. It's identifying best practice and how we roll that out as we kind of see social prescribing scaled up. And all of this builds on a whole programme of work that we did last year that was looking at common challenges and ways to overcome them, bringing over 50 different connector schemes across the whole of the UK together. We did that with yourself, Kate Joplin, our consultant, and many, I suppose, of the people who have dialed in. And some of the key challenges that we unpicked were, how do you reach those who are most in need? So inevitably, the people who are most isolated are often the least known to us. But we also identified solutions, so from linking with healthcare professionals to recruiting members of the community to act as eyes and ears on the ground, to going to everyday places and engaging with everyday people, so from pub landlords to taxi services, to promoting the schemes on local radio. I've heard that work in quite a few areas. We also identified the challenge of simply just not knowing what activities and support are out there. So how do you link people into available support if you just don't know what is available? And that, we know, I'm sure Nick will talk to it, can take a long, take up a lot of time of connectors where they could potentially be helping other people. Some key solutions to that is ensuring that the connectors have local knowledge in the first place and relationships on the ground, but also recognising when you are recruiting connectors that it takes time to build those relationships and the understanding of the local area. And of course, in some areas in particular, it can be difficult to actually connect people into support because the support just might not be available. So there's one thing about not knowing about it and another thing about it just not existing. But there are some great examples of including funding for community development, in the whole package, just a couple of £100, sometimes even less. And then you can kind of fill those gaps where they've been identified and create the activities and support that might help the individual. We also identified challenges measuring outcomes. I think do not underestimate the difficulty, asking questions to evaluate levels of loneliness and then the impact at the end of it. And often connectors and others will need training and support to use measurement tools effectively. We also identified a series of challenges that really require much greater intervention than the individuals on the ground. So right through to securing sustainable funding for schemes that will help tackle loneliness, helping people with complex needs, which, a social prescribing link worker or a connector themselves are probably not going to meet all of those needs as an individual. Tackling the stigma surrounding the terms, which often prevent people asking for support, reaching out when they need it, right through to how do we ensure that the wider community infrastructure upon which connector schemes and social prescribing will inevitably rely on, how can we make sure that that's flourishing?
Olivia, thank you very much. So again, if you joined today thinking that we were going to present all of the answers, there's quite a lot of quite some of them, but I think that reflects, so this is a really exciting time.
Absolutely.
This is it's still relatively new development where there's lots of things which we're looking to explore and understand how it can be most effective.
Exactly, and this is we are identifying the challenges, and we're investing so much in looking for solutions and gathering the solutions that are out there, because we fundamentally believe this is the right approach, and it really does. When you have that individual who can support people who are lonely or at risk of loneliness, it can do wonders for community, for individuals, for our health and social care system and our other public services. But we just need to come together and share all of the great learning that we have so that it is a success and that this does everything we hope it does.
Olivia, thank you very much indeed. Now, I realise it's very remiss of me at the beginning that you might have been looking at this lovely little glass jar here, wondering what on earth this is here. This is actually our jargon jar. It's our acronym swear box, where I have set on phone, I am watching out panel. If we slip into jargon or unexplained acronyms, I will be looking for financial contribution. I think just as you said, Olivia, just one or 200 quid is fine. That's fine. But let's not slip into terms which we don't explain. Olivia, thank you very much indeed. Bev, thanks so much for joining us today.
Thank you. The jargon jar is going to be a challenge. I'm going to do my best on it. Okay, so I work for NHS England, and we are developing a universal approach to social prescribing, and I want to explain a little bit more about this and what some of the opportunities are moving forward. We've got two really important documents. One is the cross-government loneliness strategy, which I'm sure you know well, Olivia and colleagues, and that makes a commitment that we will universalise social prescribing across primary care by 2023-24. And the detail of that is followed up with the NHS long-term plan, which came out in early January, and the general practice contract reform document. So the GP contract that's negotiated regularly has got stuff in it now about social prescribing, and we are about to produce further guidance down the line. So what does this mean, folks? That's what you're thinking. Okay, so there is a huge social prescribing movement. People here around the table and on this webinar are part of that social prescribing movement. But up until now, funding has been largely local, clinical commissioning groups, local authorities, charities, charitable fund trusts, have all been working together to fund social prescribing locally. We want to, we've got a long-term commitment for 5 years to enable every, jargon here, primary care network to
You've got to explain what a primary care network is.
But I'm going to explain what a primary care network is. Yeah. Okay. So every primary care network is eligible to apply for funding for a social prescribing link worker. So what's the primary care network then? That's new. Okay. So if you think about your GP practice, right now you'll go to your GP practice and you'll identify with that practice and that GP or whoever. We are building a team across practices. So in a local area, you might have 3 or 4 GP practices who will all be working together to form a primary care network. The idea behind this is it's a much bigger team across a local area that works really practically and supportively around what does the population need and what should we provide. So the multidisciplinary team in future will include GPs and nurses, but it will also include community pharmacists. It will include social prescribing link workers, mental health therapists, and other roles. The first 2 roles that we're bringing in from April onwards, 1920, are community pharmacists and social prescribing link workers. Social prescribing link workers are the only role that will be reimbursed at 100% of the salary. So there is funding that's available to these new primary care networks. That's who the funding will go to develop social prescribing link worker roles. I've not got long, so I'm cutting to the chase. I want to tell you about what the link workers will do, because it's absolutely in line with everybody's thinking around here. So the link worker is a key resource. It's about giving people time. It's about what matters to me, not what's the matter with me. So if you're lonely, or if you've got debt, or if you've just got lots of complex stuff happening in your life, or you're worried about feeding the kids, or whatever it is, the link worker will work with you on that to understand your key motivations and then connect you to the right community support. So I've got a little diagram on that slide that shows you the core elements of link workers social prescribing in primary care networks. Well, first is the link workers gives people time. So we're not saying you can only access this if you're lonely, or you can only access this if you've got a long-term condition, or any of that stuff. We're saying we're leaving it to primary care networks to find the right people who need this support. If you feel somebody needs social prescribing, then that works for us. And the link worker sits with a person, develops a rapport, develops trust. I'm sure you're going to tell us more about this, and then creates a shared plan with the person, and we'll connect them to community support. So there's some core ingredients. One is everything's got to be collaborative at local level, because we're all in this together, and this is about what's available and how can we support each other. It's not just about referrals from GP practices, it's not just GPs. So at first, if this is new, we're saying, okay, you can just take referrals from within the practice and the network. But as we move forward, we want every local agency to be able to refer to people, to social prescribing link workers. It's about everybody knowing what the role of a link worker is. It's about you said this, Olivia, it's about providing support to community groups, to the voluntary sector, so that there are things to refer to. And it's about what we're calling a common outcomes framework, which is measuring the right stuff. And for us, there are 3 things that we have to measure if we're going to make a real difference. One is impact on the person. Does it improve their well-being? Do they feel more in control of their lives? The second is, does it reduce pressure on the system? Does it enable clinicians, doctors, nurses, others to spend time on the medical stuff so that the link workers can have more time with people? And does it strengthen community groups? Are community groups more able or less able to be involved in this stuff? They're the things that we need to test over the next few years. So we will not stop at just one link worker per primary care network. We're hoping to build on that and to produce and to be able to fund more link workers long term. But one last thing from me, we can't fund existing roles. Oh, 2 last things from me, because there's an absolutely core thing. So we can't fund existing roles, got to be new roles. But the most important thing, and I'm actually quite proud of this, is we've negotiated that the primary care networks do not have to employ the link workers themselves if that doesn't work, because there are lots of agencies like yourselves who are already providing link worker support. So it's down to local discretion, but the primary care networks can buy a link worker from a local voluntary organisation. They can second people, whatever works locally. They've got the flexibility to do that. And that's because we wanted to make sure that we're building on what's already there and not duplicating it. Sorry, I've taken up quite a lot of time.
Do you want any additional points, Bev? 1 more, 2 more, 3 more?
No, I think I'll stop there.
Bev, thank you very much indeed. And a timely point just to say, we'd love your comments, questions, reflections as we go through those 3 ways once again. You can use that ask question feature. You can email us, hello@kaleidoscope.healthcare, or tweet. The hashtag is tackling loneliness, and the handle is @kscopehealth. And we're going to come to Nick in 1 second, but just to say, some questions are already starting to come in, and one just following on exactly from your point. So Caroline, thank you very much for joining, Caroline. Just saying, what about those connectors, those link workers that are already connected in the community? Will they be funded under the new proposal?
So we will be funding additional new link workers within primary care networks. If primary care already have the link workers, we will still fund more, but we won't be funding other schemes if they're not connected as part of the primary care network.
Okay.
Does that make sense?
So I think people might be coming back. So if an area is doing really well at this already, they already have the infrastructure in place,
they can have additional.
They can have additional. Yeah. But not fund for established.
No, so we can't fund existing link worker roles, but we can fund additional link worker roles, irrespective of what you've got in your local area. We're not going to punish the areas that have done really well. They can have extra link workers.
Thank you very much indeed. So once again, welcome comments, questions, reflections as we go through. Nick, thanks so much for joining.
Thank you very much. Very nice to be here. Yeah, so I'm going to talk a little bit about what I do as a community connector. So as I said, I'm with the British Red Cross. I'm in Islington. We've been working there for a couple of years. So as Olivia mentioned, we've got projects across the country, sort of specific local areas that we've been working for a couple of years, since May of 2 years ago. We work with people. There'll be people on the call who already know this, I think, and then there'll be some people for whom this might be new, so I'll try and keep it fairly brief. So working with people for up to 12 weeks, which I've tended to interpret, and I think a lot of other people have interpreted as sort of more 12 sessions of usually around a couple of hours. It doesn't need to be 12. I think we've tended to find that slightly fewer is generally better for the relationship that we're building with people, but it needs to be enough time that we can build up a level of trust and kind of understanding between ourselves and service users. I'm going to call them service users.
Okay, thank you very much. People, individuals.
It is easier for me rather than trying to change what I say each time. By service users, yes, I mean people that are accessing our service that we're working with and sort of helping to overcome some level of loneliness or isolation or other barriers to connecting with different services in their local area. So yeah, a lot of that time is spent in discussion, often visiting people either at home or in the community somewhere that they're comfortable. And that has been at GPs and it has been in cafes, but more usually at home for me. And it's been a question of kind of going through with them what their barriers are to doing things that they want to do and what things it is that they would particularly like to be able to do. So a lot of time that will be somebody who maybe is struggling to kind of meet people and feel socially active for one reason or another. So potentially we would then be helping them to find activities that they can engage with and helping them to go along to try out those activities and maybe going to 2 or 3 different places or different types of things so that they can feel that they've got a range of options, but building their knowledge of what's there and building their confidence in going out and doing those things. And I think those 2 things really need to go side by side. It's really important that that those service users feel not just that they have the information available to them, but that they really understand what that is, and they feel comfortable going out and doing those things. I have had more than one service user who has kind of straight up said to me, you can tell me what's there, but I won't go. I will not be able to go on my own. And sometimes that might be 2, 3, 4 times that they're not able to do that. So that's been really key for us, being able to kind of not just link people with information, but physically support them in going to an activity or to a support service. It may be that actually what they need is to be able to get out and talk to somebody about benefits. Now, I don't know the benefits system. A lot of people don't understand the benefits system very well, but there are people available in local areas who can really help with that sort of thing. And for somebody who is quite socially anxious and potentially quite isolated, either the going to the travel aspect can be quite daunting, or it could be the going into a new place and meeting somebody and maybe just having a friendly face with them who can either just sit there and listen and add a couple of points here and there if it's relevant, or make an introduction, or anything, obviously depending on the relevance of the situation. So there's a lot of that. There's a lot of kind of an emotional support side of things, helping people just to talk through things, what I sort of term like low-level counselling. We're not, unless kind of previously, we're not particularly qualified therapists, so it's obviously there's a limit to what we can offer, but certainly the fact that across all of the British Red Cross, one of the main things that we talk about is listening to people, and just kind of making sure that we're sort of helping them to work through and talk through difficulties that they might be facing, rather than jumping straight in with the information. And I know that is something that's not possible for a lot of people that they might see. I mean, for your average GP, meeting somebody, having maybe a 10 or 15 minute slot with them, that is not feasible. You can't sit and listen to all of the problems and just kind of nod and say, "Oh, that sounds tough." You know, that's not your role, and you can't do that. And I think that's something that's been really important for what we've been able to do. I think the other thing which has been brought up, I think, by everybody so far is having the local knowledge, knowing as much as possible what is available, or who to go to ask about what is available for a wide range of different issues, whether that is somebody who wants to find a knitting group, or somebody who needs help with benefits, or somebody who just wants to be able to go out and walk in a relatively quiet area. You need to know that person's local area, and you need to know more than one option for them in that area, because otherwise that conversation breaks down. There's really not very much we can offer them. So I think one of the things that I, and I'm sure a lot of other connectors within our role, spend a lot of time doing and still spend a lot of time doing is really going out, meeting people who are running services, getting a chance to talk to them and understand what it is that their service offers, and potentially trying out different parts. So I have very fond memories of going to an over 60s exercise group because I wanted to know what it was about, and I asked if I could just kind of sit and watch, and she said, "You can take part if you want." So I did, and those over 60s ran me into the ground. But it meant that I could then go back to the people who were interested in that exercise group and say, you know, it's like this, I've done it, you know, I know what the people are like, I know what the instructor's like, I know exactly what's going on, and because within my role I have time and I have the sort of the flexibility to go and do that and to kind of join in with tea groups and spend a lot of time sort of really researching the area and understanding. I think that that's something that not a lot of other organisations are able to offer, and I think within any kind of link worker or connector scheme, it is really important that there is sort of a wide knowledge base and an understanding of what is available, and potentially an understanding of what other people are not able to do or what other people won't know about, and maybe trying to help them to build their knowledge bases as well.
Nick, thank you very much indeed. And thank you to everyone who's already sending through a whole plethora of questions. I think we're going to extend this from an hour to about 4 days. If that's okay. You guys got nowhere else to be. You've probably got your over 60s exercise class to get to at some point, Nick.
Well, yes.
We'll see what we can do. So thank you very much for everyone sending through questions. What we're going to go on to now is we are certainly going to come to those questions in just a moment, but we've also got a whole host of questions for you, which we will bring up in just one moment. But just to say, a whole range of questions coming up, and a whole set of factors to do with social prescribing. I'd say just for today, if we can have questions particularly focusing on how can social prescribing be most effective in tackling loneliness, that would be great. I think what we will do is, if there are any questions we don't manage to answer within the hour, then we'll try and come back to people, whether we do that over Twitter or we email out a whole host of FAQs afterwards. We will certainly do that. Right, okay, questions for you, the audience. So you've had your 36 minutes of listening to insight from our panel. So we've got a whole host of things here, where what we'd really appreciate is, we'll leave these on the screen for the rest of the session, is to say that if you look through these and you think, right, I know the answer to that one, or I've got a particular insight I'd like to share, please do contact us. Again, those 3 ways are using the Ask a Question feature, which can also just work for comments as well, or send us an email, hello@closescope.healthcare, or use Twitter. So we're very much wanting your questions for us, but also we would very much like your insights, your collective wisdom, for those who are joining on the call, in terms of your questions, of our questions for you. So we're going to run through very quickly. Nick, do you want to read your 3 questions?
Yeah,
3
absolutely.
questions for the class.
So my first question, kind of based on our findings in Islington, that there tends to be a significant gap in the sort of the ability of people to be accompanied to an activity or a service. There are not many, if any, other organisations that offer that. I'm really interested to know what sort of other gaps there are in in other areas that need to be filled either by a link worker or somebody else. Second question would be to do with broadening people's knowledge of what's available for referring organisations. So making sure that they know lots of different places that they can refer to and how to make that as easy as possible, because remembering lots of organisations is tough. And what 2 or 3 ways we can best ensure safety and well-being of frontline personnel in what is quite a taxing role.
Lovely, Nick, thank you very much. Bev, your 3.
Okay, so what are your biggest challenges? That's one question. The other is, how can we bring all local partners together to create shared local prescribing plans? I haven't talked about that, so I'd like to come back to that. And then the other thing is, what support does the voluntary sector need? What support do we need to nurture those community assets?
Lovely. Lydia.
Quite simply, what is the main risk to social prescribing tackling loneliness effectively, and how can that be addressed, of course? What is the most important feature of a successful social prescribing model for loneliness? And also, how can healthcare professionals, and I should say others from other local agencies, be supported to understand how to identify loneliness and routinely refer people into appropriate schemes?
Lovely, thank you very much indeed. It's like a competition for who's got the most insightful, hard question to answer. So again, what we'd really welcome, so your reflections, your insight, going back to the sort of wealth of views we've got on the call. So if there's something you've been doing locally or something you're aware of, which refers to any of these, please do get in touch and share. But we'll just start with Olivia, your first question around the main risk to social prescribing, tackling how social prescribing can tackle loneliness effectively. So we're going to give you, I think, 5 options. It's another poll. So 5 options. And what we'd like, just of those 5, and we know that it's an incomplete list, of those 5, we'll launch the poll now. Which would you see as the biggest risk to social prescribing tackling loneliness effectively? Your 5 options are there on the screen. So a lack of funding for community infrastructure, complex cases, how you go about establishing strong local relationships, how you recruit and train link workers, how you identify those most in need. So 5 options. So again, if you think we've missed out a huge risk there, you're very welcome to get in touch to us. But just of those, what is your view of the main risk? And that's just coming through. 53% of you voted. We'll give it another sort of 15 seconds or so, starting to see which way it's going to go. So we'll come to our panel in just a second for reflections. Great, I think we will call it there. Thank you very much. We gave 5 options, and there's a distinct winner, which is 54% saying lack of funding for community infrastructure, followed by identifying those most in need, followed by complex cases, recruiting, training, and then establishing strong local relationships coming towards the bottom of those. Thank you very much indeed. We'll hide those results away and come back to our questions. So reflections from the panel just on those points. And we've had a whole host of questions around the funding element. So Bev, I wonder if we could start there.
Yeah, absolutely.
Obviously, a strong message from all the work on Fund Care Network that there will be funding. People are sort of questioning exactly how that's going to work.
Yeah, and I'm picking up a couple of questions that people have sent in. So, there's one of the questions is around, is there a perverse incentive to decommission good schemes? And I've really worried about that. Wherever you put funding, it's problematic, and there's always consequences. So one of the reasons why we've enabled primary care networks to work with community organisations is to avoid that. But the other thing that we're asking local areas to do at CCG, local authority level, in your local places, we want the clinical commissioners to bring together all their local partners, including the voluntary sector, to create a shared local plan for social prescribing. And basically that shared local plan, what we want to do is to look at how can you build on what's already there and not duplicate. There are some areas where they've already got lots of link workers. Islington might be one of them. They've lots of different things happening. Here's this new money. how can we use it to make sure that every primary care network has a link worker, but that we are using the resources of the local area? One last thing from me. So we're not, the NHS is not able to fund all those community groups that are receiving referrals. That's just not practical. But local areas, local partners should be working together to fund those local groups and to nurture community assets. We're seeing that in lots of areas. We'd like to encourage it. I think that's our biggest challenge moving forward, is how can we encourage local areas, local partners to work together to really resource the voluntary sector and community groups.
We'll come to Olivia in just a moment, but Nick, how do you see this sort of playing out in the ground in Islington?
I think it's a really good point, and actually it touches on some of the questions that are coming up here as well. We in Islington, there are a lot of fantastic organisations doing a lot of really fantastic things, and I think that yes, funding all of those would be nigh on impossible. And actually they're already there, they're already running, they're already getting their funding from somewhere, and actually better to use the funding to pick up some of those areas that aren't currently being filled. I think the difficulty is going to come with things like outside of somewhere like Islington, where there are not the resources available. You can have all the link workers you want, but if you can't, so I mean, to pick up on one of the questions that really highlights sort of an issue of mobility and transport, within Islington, that's not so much of an issue because it's very well connected transport wise, and there are good mobility schemes, but there will be areas where that's not such a sort of an availability, and where there may only be one or two sort of activities, and they might be quite spread out. For somebody to get to those is going to be much more of an issue, and you might end up then funding workers who can recommend things which are not in the end actually attainable, and even if that link worker is somebody who can actually facilitate through driving, it's a question of what happens when that person's no longer available. And I think that's something that needs to be looked at across the board. It's going to be different for each area.
Nick, thank you very much indeed. Olivia?
Yeah, I would just echo that. There's one thing of, yes, there's an absolute need to invest in the voluntary and community groups that are inevitably going to see a rise in demand as social prescribing kind of expands and becomes more of a kind of daily thing that happens. But there is this whole infrastructure that needs to be in place as well. So I mean, particularly in rural areas, transport is huge, and if there's no bus or there's no community transport that you can get to a particular group, then how does that person keep going there in the longer term? And we're been talking to different stakeholders who are saying, well, actually the longer term community groups and activities and support that aren't just the kind of link worker who's going to be there temporarily, need to plan their support, their service in line with the current transport. So what time does the bus come from certain areas? Local commissioners need to be thinking about investing in schemes in line with their thinking about transport as well. So all of this needs to come together, otherwise the whole thing might just come apart.
Lovely, thank you very much. So it seems there is the risk, I think, which people are flagging again in the questions, that we end up with well-funded connection schemes but little places for them to go on to. A whole host of questions coming through, so I'm going to throw a couple out, if that's okay. Well, firstly, for Nick, if that's okay, a number of questions around how you get the balance right for link workers in terms of being that sort of generalist role, which you sort of talked about earlier, being able to sort of work the whole host of individuals, versus having more specialist skills for particular circumstances. So how you get that balance right, it'd be great to get your view on that. And Bev, a number of questions about successful social prescribing not just being all about engaging GPs, but engaging wider healthcare professionals as well. So how do you do that? Okay. And then Olivia, I'm going to think up a really difficult question in 1 second. Nick?
I think that's a good question. I think I would answer that by saying actually that I see my role as the generalist, and the whole purpose of me doing what I do is that I can help people to access the more specific things that they might need. It's not for me to be there run every single activity and help with every single therapy issue and every single kind of logistical problem that somebody might have. It's for me to listen to the problems and help people to find other organisations that can deal with it. And to give a practical example, we've recently had somebody who is looking for a grant from a community fund. Now, technically, I can go through all of the paperwork and help them to access that. I don't personally think that's the right use of my time. I think the better option for me is to signpost them onto the local organisation in Islington, which happens to be Age UK Islington, who are also able to do all of that. It A, means I've got more time to spend with my service user on other issues which they may be facing, and B, means that next time they have a problem where they need to access a community fund, they're not trying to go through me, who I've moved on to work with somebody else. They go back to Age UK, who are still there and still able to help with that issue. And I think that's more important, that people are resourced for the long term rather than me trying to do everything for them for the short term.
Lovely. And so it seems certainly there's something here about that clarity of roles and responsibilities, and having that local understanding about how best to use people.
And I think crucially to make sure that the service user is given as much of the ability and the sort of the power to do those things for themselves. They don't need me to make a phone call for them most of the time. They can probably do that as long as they've got the phone number and they maybe had an introduction to who they're calling, and that's probably a better long-term solution.
Thank you very much. Bev, beyond GPs, how do you engage others in social prescribing, and that being part of their, as we talked about before, built into the fabric of their everyday work rather than just an add-on?
So we've got to do all of that. So this is about a local ecosystem, a social prescribing ecosystem.
An ecosystem? What do you mean by
everybody working together for maximum collaboration? So everybody's, understanding their different roles and thinking about how can we do this so to make the most bang for our buck. So every professional group, whether that's a social worker or an occupational therapist or benefits agency, need to understand the role of a link worker and what's the right kind of a referral, so that they're not making the wrong referrals and they're really getting the right people for support. In many areas they're already doing this. It's evolving naturally, and it will evolve in our new world, but it'll evolve best if we work in partnership together and are really committed to that part. It won't work if we don't do that.
Within the ecosystem?
Within the ecosystem.
Yeah, lovely. Composting, is that helpful? Good. Bev, thank you very much indeed. Again, please do send us comments, insights across those range of questions there. Olivia, you posed this question about what's the biggest risk. That funding beyond the link work themselves coming up trumps. What's the way out of this? What do you think is going to be key for local areas to be able to do exactly as Bev says, to be able to work effectively together and find the funding to ensure that infrastructure does stay in place?
So, I mean, there's obviously no one simple answer, but I think there are different components. So I think when we're talking about relationships, we need to think about all the different relationships that you need to have. So there's relationships between all the different community groups and everything that you might be linked into as an individual who's been helped by a social prescribing link worker or a connector. But then there's also the relationship to all the people who will typically refer into these link workers. And that relationship is more than just, you need to have kind of a positive relationship, you need to know about the link work, you need to be sold as a GP or as a nurse that actually tackling loneliness or these other non-clinical issues is an important thing to do. You need to be sold for the first point. That's going to require cultural change and shift in a lot of areas. So we need to do a lot more to show the importance of tackling loneliness and unwanted isolation. But then we also need to give all of these typical referrers the tools to actually know what to look out for, to know that perhaps somebody who once used to look you in the eye no longer does. What might that be a sign of? To know the right questions to ask, to know, like we're seeing in a lot of areas, that people still typically assume that older people are the only ones who are at risk of loneliness, and indeed other non-medical issues. But we know that lots of younger people are too. So we need to change people's mindsets and give them and make them understand what it is that they need to look out for. Then we need to equip the link workers with all the social skills to make those relationships. And Nick was actually saying earlier about how important certain characteristics are when recruiting connectors, and just people just having those networking skills in itself, and the confidence to go out and talk to people. That sounds really simple, but that is so important to the success of the social prescribing link worker schemes.
Lovely, thank you very much. And questions still coming through. Thank you very much indeed for those. A number of questions sort of coming from the service provider side. So I wonder, Olivia, we can start with you, then Bevan, you might want to come in terms of what your advice be for service providers wanting to link with link workers. How can they best connect to connectors, so to speak? But also, is there what's the longer term plan here? Tim, thank you for this question. When voluntary organisations receive an increase in demand through social prescribing schemes, is there a risk here that if what we want to happen happens, it creates a whole new set of issues? I'm going to say we've only got a couple of, we are fast coming to the end of our time. So Olivia, very quickly on advice for provision organisations. We'll come and do reflections in just a second.
So connecting with your connectors and link workers, I mean, I hope that it will be a lot easier to do that when all of the primary care networks have their own social prescribing link workers. Hopefully they'll be well published. For now, I think it's important to remember that really annoyingly, we're all using different language to describe these. Yes. So we've got community connectors, we've got navigators, we've got link workers, we've got social prescribers, and so on and so on. So do remember that we're not always using the same language. You can start off by looking at the Red Cross website to see if we've got available connectors in your area, but there are plenty more local authorities often providing them as well, as we can find them in certain GPs already as well. So unfortunately, there's no simple, easy way to find all of the connectors, link workers, whatever we want to call them, across the country, though I know that is also on the kind of national agenda to look at solutions to that as well.
Lovely, Olivia, thank you very much. I'm going to move on if that's okay. I'm really sorry, we're so deluged with questions and insight that we are going to come just to our closing reflections. And so I'm going to just come to everyone on the panel and just ask for one particular insight or one particular reflection which will stick with you following today's discussion. But just to say ahead of that, again, we'd really welcome your comments and insight across this host of questions. And equally, if you think there are other questions around how social prescribing can most effectively tackle loneliness, which aren't on that list, please do flag those, particularly if you want to share insight around them. Following today's discussion, we'll be sending around details of the wider project, including a further face-to-face event coming up, which may be of interest, so watch out for that. And if there are sort of friends or colleagues who weren't able to join today who you think could benefit from watching back, or might like to see the list of questions to share insight, please do share those. I hope that has stalled for time sufficiently so that we can go around and do closing insights. Shall I start just to buy people more time? I'll start and then go Nick, and then Olivia will give you the last word. So closing reflection for me is it's sort of that funny mix of emotions of excitement about being able to see potential, but also being slightly daunted that there are so many issues to think through. And I think often we can think about something like social prescribing as binary, as in you have it and it's great, or you don't have it and it's rubbish. Whereas it's so obvious that there's a whole host of sort of detail to work through in order to make this most effective. And thank you again for everyone's insight in helping to identify a whole range of those issues. Next.
I think I'd echo your excitement. I think the idea of having link workers or connectors with a clear link to their local NHS groups is going to be fantastic. I can't see any way that can't be a benefit I think that the key thing, the crucial thing, is going to be that those setups are sort of flexible to the area that they're in, and that they're able to, as I think has happened before, they're able to mold themselves around what is needed in that local community and really meet the needs of those people.
Lovely, thank you. Clever.
It's all about trusting relationships. That's the only thing that works, whether it's between agencies or between people. Trusting relationships is the bee's knees.
Thank you. Olivia, the last word.
So I'm just really pleased with how many people have taken part again. I just continue to be kind of amazed and overwhelmed by the number of people who are interested in this issue. But I know that from our kind of poll at the beginning, lots of people coming here with different experience, and I see that we've got a lot of responses to our questions, comments, positive and negative, but this is all why we're doing this. So hopefully all of these different perspectives will help us develop some really kind of practical, tangible recommendations to take this forward so that it's a success.
Lovely, thank you very much. So there's one last task before we leave, which is what we'd love to do, just to finish, is, so you've got those list of 10 questions in front of you. We're not going to set up a poll for this, but we'd love to know which, if we could have a definitive answer to any of those questions, which of those would be most helpful for you in your day job. So if we could definitively solve any one of those 10 questions in front of you, which would you most like it to be? And so closing ask on you is, if you can, just send a message, hello@kaleidoscope.healthcare, or just put it in the question function. Either of those is absolutely fine. But which of those would you most like to be answered? So you can put like Nick 2 or Bev 3 or Olivia 4. It'd be really interesting for us. Do these questions resonate with you? Which are the ones which we particularly need to focus on? Going back to your point, Olivia, about making really practical recommendations. We're not interested in just admiring the problem. We'd quite like to actually try and solve it. So final request, put in which of those questions you'd most love a definitive answer and help you do your day job. And with time at 2 o'clock, we will then close. Thank you once again, panel. Thank you everyone for joining. And again, we'll be sending around details of how this project will develop. Thanks again all. Goodbye.